Hello, everyone, and welcome to this audio podcast. This audio podcast is part of a segmental Scruples edition or series. This audio podcast is part of a Rampage Sonar. This audio podcast is part of a Blitz Lobostics, and this audio podcast is part of a Storm Lobostics production. In this audio podcast, I'm looking at theme two, and managing anemia in the chronically ill, in the chronically ill or untransfusable, the sort of untransfusable sort of the untransfusable patient or recipient. So it had been highlighted in at a sort of annual scientific conference, sort of retrospectively in around 2015. For example, that there are still ongoing issues and concerns with regard to managing anemia for patients or recipients, despite a guideline or initiative even referred to as the Better Blood Transfusion Initiative, and the Better Blood Transfusion Initiative, sort of initiative was founded by sort of the UK chief medical officers to improve the safe and appropriate use of blood. The initiative began in 1998 and continued until around 2012 when it was suspended by when it was superseded by Patient Blood Management or PBM, and the National Blood Transfusion Committee or NBTC had a major role in overseeing the Better Blood Transfusion Initiative in the UK, or in England, or in the UK, where there was transfusible success, including a reduction in the morbidity and mortality associated with transfusion, documented by serious hazards of transfusion or shot, and a reduction of 20% in the use of RBTs. So at the Congress, at this annual sort of scientific Congress in around 2015, at the same time, concerns that had also been raised include number one, patient safety; number two, demand for blood and shortages; and three, evidence of broad variation in practices across the United Kingdom. The presentation, one of the presentations at the annual Congress highlighted that there needed to be better consensus to ensure that the better blood transfusion initiatives are made in an integral part of NHS or National Health Service transfusion care. In addition, scientists, healthcare professionals must endeavour to avoid unnecessary transfusion and establish protocols or procedures to empower blood transfusion laboratory staff or specialists so that they can query and prompt discussion about the appropriateness of requests for transfusion against local guidelines for blood use. It is important more so than ever. At the same time, the evidence-based and multidisciplinary team efforts or MDT efforts are made because professional shared decision making optimizes care and ensues the best treatment options are made. In the decision making process, of critical emphasis is that a patient's wishes or recipient's wishes are taken into account. Consistent with more recent changes in perioperative transfusion practices, namely the lowering of the transfusion trigger. So recall in a previous audio podcast I mentioned there was a mention around the threshold, around the hemoglobin threshold being less than 10 grams per deciliter. 10 grams per deciliter, for example. This And then in sort of more prospective works, again, there has been works around the lowering of the sort of transfusion trigger. So for lowering the sort of transfusion trigger for RBTCs, RBTs and RBCs, or red blood cells. One investigation, for example, have found that severe anemia after major surgery is now or has been a common occurrence in consecutive patients or recipients who have undergone sort of surgery and had been screened. 25% were found to be severely anemic on the morning sort of post surgery, with a hemoglobin concentration between 70 to 90 grams per deciliter. And the team and the investigation had informed that early post-operative treatment with IV intravenous iron alone, for example, or in combination with EPO, erythropoietin, does not appear to accelerate early recovery from post-operative anemia. Um, Post-operative anemia. Now, at the same time, unfortunately, at present or currently, little research has been conducted or carried out to understand or replicate sort of the investigation and establish whether managing anemia in chronically ill or untransfusable patients or recipients in the same manner would be advantageous. Such prospective research is required to make comparisons. And so for many years, an arbitrary transfusion threshold of uh, of uh, of 100 grams per liter, or 100 where the reference ranges, again, sort of listeners, is sort of in hematology laboratory, in context of hematology laboratory and reference ranges. I've said 10 grams per deciliter, but at the same time, this is using sort of the units that are sort of are sort of are sort of sort of sort of comparable between, for example, laboratory reference ranges, where 10 would be, for example, 100, but using different but using utilizing different reference laboratory reference ranges. So 10 would be 100, and 9 would be 90, for example. Um, and um, and the an arbitrary transfusion threshold of 100 grams per liter, or around 100 had been broadly implemented in clinical medicine, including treatment of critically ill patients. A reevaluation of practice was prompted in the mid 90s because of the anxieties of transfusion related infections, such as acquired immune deficiency syndrome, and the prospect of ever decreasing blood supply. Larger clinical trials had been required before sort of the sort of broad implementation of treatment guidelines that advocate the lowering of transfusion thresholds in critically ill patients or recipients, but also take into consideration the renal status of such recipients patients accordingly. The British Committee for Standards in Hematology, or BCSH, guideline from the BCSH guideline, sort of retrospectively, had informed that anemia should be identified and treated ideally at least 6 weeks before to any planned surgery, and the etiology and background and source to and sort of basis to anemia should be investigated before to any again before sort of any planned uh, to any sort of planned sort of surgical procedures. And the clinical history of a patient or recipient needs to be understood, especially if evidence of long-standing condition or chronic illness that may complicate perioperative or post-operative recovery. Also of critical importance is to make sure that number one, C-reactive protein or CRP inflammatory marker is to make sure that C-reactive protein or CRP inflammatory marker. Two, a reticulocyte count, Number three, hemoglobinopathy screening. Number four, establishing any evidence of previous bleeding. And five, evidence of renal impairment need to all be established in the management of anemia in the chronically ill, and potentially untransfusable recipient or patient. So in the untransfusable recipient or patient, it is still to be piloted through sort of larger trials as to whether EPO or erythropoietin has broader advantages over RBTs or blood cell transfusions, especially in patients or recipients who might be more at risk of transfusion-like reactions. In another investigation where a team explored or investigated to quantify the association of EPO use with hemoglobin recovery in anemic untransfusable hospitalized patients, EPO-treated anemic untransfusable patients were identified through a combination of retrospective case review and systematic reviews. Literature reports of untransfusable patients not treated with any EPO were used as a comparator group, the comparator cohort, and this team had established or identified. One team had established that hemoglobin recovery rate was actually higher in patients with lower baseline hemoglobin levels, irrespective of EPO use. No association was identified between the rate of hemoglobin recovery and EPO use, dose, and or therapy duration. In anemic untransfusable hospitalized patients, EPO use was not associated with an increased hemoglobin recovery. This study on the investigation, however, did not look to determine renal health or serum creatinine of untransfusable patients at baseline, which could provide some important insights of how to provide transfusion care in patients with renal insufficiency or patients who may have long-term condition or long-standing conditions and or chronic illnesses. And this is definitely a need. There is definitely a need for for and against a sort of debate here on the way transfusion care is managed and practiced in future. As the prevalence of CKD also increases, or the prevalence or the incidences of CKD, chronic kidney disease, also increases in the general population, this will result in renal insufficiency. Would result in renal insufficiency in recipients or patients with long-term conditions or chronic illnesses, potentially warranting more up-to-date guidelines more up-to-date sort of guidelines and research. That draws this audio podcast to a close. This audio podcast is part of the Segmental Scruples edition or series. This audio podcast is part of a Rampage Sonar. This audio podcast is part of a Blitz Lobostics. This audio podcast is part of a Storm Lobostics production.